Right, sir. So I'll be presenting on diagnostic accuracy of strain echocardiography in determining myocardial viability in out-of-window period anterior MI patients in comparison to SPECT. So again, this work was carried out under the supervision and guidance of my mentor, Professor Yashpal Sharma at PGI. So anterior MI patients account for the vast majority of MI patients, and as such, they confer a worse prognosis, and there is increased chances of left ventricular failure, malignant arrhythmias, and death as compared to any other form of MI. Immediate revascularization, of course, is the key. But in India, we know there are a lot of late presentations and who do not have any ongoing chest pain. Often on echo, they have an akinetic territory. So often the clinician is faced with a dilemma how to proceed from here on. So viability has remained a matter of debate over the last 10 years. There have been multiple trials, Stitches, Christmas, and another by Perry et al. So as of now, the consensus, again published as an editorial in European Heart Journal this year, remains that viability does matter, and it ultimately does predict functional recovery and prognosis. So it should be done whenever it is applicable. So keeping this in mind, we conducted a single-center prospective observational study and recruited all patients presenting with anterior MI outside the window period who did not have any ongoing chest pain and had an akinetic territory on echocardiograms. So after the recruitment, so we did SPECT as well as strain echocardiographic images within the first 48 hours of recruitment. Speckle tracking is a very user-dependent tool, and as such, if you're not adhering to strict guidelines, you're bound to make inaccurate assessments. So that was ensured by sticking to the guidelines laid down by White et al. In 2015. Territorial longitudinal strain was taken from the 6 segments in the 17-segment American heart model as laid down by Serker et al. In 2002. So we took the mean of these 6 segments, and that corroborated with mean territorial longitudinal strain. So SPECT was again performed in a dedicated CZT camera according to standards protocol at a center, and a matched defect of more than 5% was taken as a marker of non-viability. Inclusion criteria, as I've already told, importantly, we excluded patients who had any ongoing chest pain or were otherwise candidates for immediate revascularization. And other exclusion important criteria was poor echocardiographic window and inability to clearly delineate the endocardium, because we need very good quality images to have accurate assessments from the strain. So we took 51 such patients with a mean age of around 60 years. And importantly, our patient's profile was relatively sicker, and almost 20% had both left ventricular failure as well as cardiogenic shock, meaning thereby a high-risk subgroup. Ejection fraction, the mean ejection fraction was 30%, the mean GLS and TLS was 11.4 and 7.7 respectively, and on SPECT, 35% of the patients had non-viable myocardium. As to the predictors of non-viability on SPECT, apart from cardiogenic shock and left ventricular failure, importantly, both GLS and TLS were related to non-viability. And on ROC curves, there was indeed a very good sensitivity and specificity with ROC values of almost 0.9 in endocardial GLS and more than 0.8 in endocardial TLS as well. This is in that can be compared to the recent to all the modalities that we have. So the roughly sensitivity and specificity approach is the same number. Layer specific analysis was also done because we know ischemic process is layer sensitive and it predominantly involves the endocardium, but still we looked into all such parameters. There was as such no difference, and all of these all of the 6 endocardial strains did all of the 6 longitudinal strains, I'll say, did correlate with viability. So just as to give you an example, so I am sharing 2 of our cases which are very similar in most aspects. So both are middle-aged men and both have had an anterior MI. Angio was done on both had subtotal lesion in the proximal LAD. So the first one, if you see, has a very good strain curve and relatively preserved GLS territorial strains in the LAD territory. As compared to the second, you can see the blue dot out there, meaning reduced strains in the LAD territory. So the first patient on SPECT had a completely viable myocardium as compared to the second who had 44% non-viability on SPECT. This is again a strength of our study, reproducibility analysis. So it is important to demonstrate reproducibility because you want to generalize your results to other areas, and again alpha coefficient of variability was almost 0.9 for most parameters, indicating excellent reliability and repeatability of the test. So moving on to the discussion, so determining the viability is important, and it not only guides management but also is important for the prognostication of the patient. Cardiac markers, ECG and simple echo has been shown in many studies it is less than 60% sensitive and specific, so it is clearly insufficient to measure viability. we have tools that have shown good accuracy in multiple studies, 4 of them notably PET and SPECT. But there are caveats with all of these. So PET and SPECT will have need administration of a radioactive isotope, as well as they take time to be performed. They are expensive. The other is the CMR, again, which takes time. It is yet early stage for CMR in India, and it cannot be performed in acute kidney injury patients, which is fairly common in cardiogenic shock and left ventricular failure settings. Dobitamin stress echo is practically impossible in a patient of anterior MI who otherwise are at a very high risk of malignant arrhythmias. So there is a direct. All in all, we know that all of these investigations take time to be performed, and in an ongoing patients with an ongoing ischemia, so that translates into loss of valuable myocardium. So what has strain echo to do in this arena? So there have been studies mainly in chronic LV dysfunction, where it is widely validated and correlates with functional recovery as well. ACS settings also the data is coming up in comparison to SPECT and CMR. But mainly it is in NSTEMI patients. Very limited studies have so far focused on MI patients, and there have been only limited studies focusing exclusively on anterior MI patients. So we focused on anterior MI, which is a fairly common scenario, and most of us face this scenario day in and day out as to what to do, how to proceed in a stable patient who has recently had an MI. We gave the specific cutoffs of both GLS and TLS, and we could show excellent accuracy in comparison to SPECT. SPECT was taken in the study because it is the most commonly used mode of viability measurement at a center. Of course, there are obvious limitations. We had only a single center study with small sample size, and we cannot generalize our results to other coronary subsets. A major limitation, I'd say, was the lack of angiographic correlation. We know that the 17-segment AHA model by Sarkar et al. May not corroborate in each and every case, and as such in ischemia, there are often dual zones of perfusion because of collateral formation. So again, you cannot strictly maintain the 17-segment analysis and do an analysis. So in conclusion, I'd say that treatment strategies in patients presenting outside the window period is largely guided by the hemodynamic status, but to a great extent is also influenced by the viability. Modalities like CMR, SPECT, or PET are resource dependent and take time to be performed. Besides, these investigations are very challenging in frail, high-risk patients who might not be shiftable for the same and have ongoing renal dysfunction. So strain echocardiography using speckle tracking provides GLS and TLS, both of which have good sensitivity and specificity in predicting viability, as was shown in our study. Further, that can be safely performed at the patient's bedside in a high-risk group in a timely manner. Thank you.